And this is the title of my talk. These are my disclosures. And this is the outline of my talk. I'm going to start talking about the burden of this infection of respiratory viruses. Mainly, I'm going to focus on 3 viruses for the sake of time. I'm going to talk about RSV first, para-influenza, and at the end, few slides on influenza, and only in stem cell transplant recipient. So a very specific patient population that I deal with in Houston. And I'm going to show you some new data with a new drug that I presented in ID Week 2 weeks ago for para-influenza, which sound promising. So a little bit of background about respiratory viruses in immunocompromised patients, not only in stem cell transplant. And we worry about maybe 3, 4, or 5 of these viruses, but the main one, or the most common one that we see as a seasonal pattern, it's going to be RSV, para-influenza, and influenza. Although we see lots of rhinoviruses, but the impact probably in transplant patients is not as bad as the one that I mentioned. What we worry about in these viruses is the progression from upper in the sinuses down to the lower. If patients have now pneumonia, or what we call lower respiratory tract infection, their mortality will increase. They don't die when they have only upper. They die if they develop pneumonia. Some of them progress to respiratory failure and multi-organ failure and die. We look for risk factors for these outcomes, like lower respiratory tract infection or mortality. And the main risk factors that you need to remember are usually age, if they've been smokers, if they got allotransplant, put them at risk when you compare to auto or other type of immunosuppression. High-risk transplant, like mismatch or match unrelated, cord blood, haploidentical. If they have graft versus host disease. Neutropenia and lymphopenia are main or major risk factors in transplant and respiratory viral infection. And as you see listed here, many other risk factors. As I mentioned earlier, we worry about progression to pneumonia, so we have to act early before they progress. If not, as soon as they progress, their mortality will go up quickly. What you need to remember also for respiratory viruses in immunocompromised patients, first, high risk for pneumonia. They can get superimposed infection, either bacterial, but also fungal. There's good data out there now showing post-influenza invasive aspergillosis, and they had a great session yesterday actually talking about that. Nosocomial infection. It's not uncommon, unfortunately. When we look at our data, between 5 and 10% of our respiratory viral infection occur while patient is in the hospital. And this is our responsibility because we give it to the patient, and patient may die from this infection. It depends on the stage of their treatment. Viral shedding could be prolonged, meaning that if our patient gets the infection and you keep on checking for these viruses, it may still be positive up to 6 months, 1 year, sometimes, especially for the rhinoviruses. That's what the problem with rhinovirus, more infection control problem than impact on outcome. And don't forget that we may get an outbreaks in the hospital from these viruses. We had one last season for influenza, where on one floor in our hospital, we had 8 patients with nosocomially acquired influenza infection. And some of them actually die with this infection. So this is unacceptable, and we need all to be vaccinated against influenza and take any precautions. So this is the burden of these infections. Let's talk a little bit about management, because this is important in the viral world when we don't have much of antiviral. It's not like the antibacterial that we have lots of options. For antiviral, we don't. So what do we do to at least help this patient and prevent pneumonia or death? I'm going to start with the case. A 36-year-old male with acute myeloid leukemia who had match-related donor transplant, day plus 65. And he presented with fever, runny nose, and a cough for 3 days, and this was early December. So the month is important. Depends what season you have the winter, which month you have the winter. This is important. In Houston, this is winter time. His absolute neutrophil count, 1,200, absolute lymphocyte count of 350, and platelet of 20,000, creatinine of 2.5. We get chest X-ray right away. Any patient, even with only fever, even without cough, any patient with respiratory viral infection, you have to get a chest X-ray. You'll be surprised how many patients will have an infiltrates or pneumonia even with not much of symptoms. Don't rely much on symptoms. He had the fever of 38.6. Everything else is normal. He had a little bit of wheezing on auscultation. So question for you, what is the most likely etiology? How many of you will say it's RSV, or respiratory syncytial virus? No one? What about influenza? You're shy this morning. Para-influenza, any of these viruses? Or what about none of the above? Is it viral infection? What about all of the above? How many? Actually, it's all of the above. The main point from this question is you cannot differentiate by looking at symptoms only. Because immunocompromised patient, they can present with any kind of symptoms for respiratory viral infections. Could be minimal or it could be lots of symptoms, but it's hard to differentiate symptoms. So know what's going on in your hospital or in the community. Sometimes I look smart when I tell the fellow, I'm sure it's RSV, because I know what's going on in Houston and what's going on in the hospital. If we're seeing RSV only, so most probably this is RSV. If I'm seeing influenza only, I know it's influenza. So look at the community, what's going on, and in your hospital. So next day, nasal wash came back positive for RSV. So this patient had RSV. And what would you treat? What would you do? Would you treat with aerosolized or oral ribavirin, or IVIG only, or maybe combination of both, or you don't treat? Or you call me, and that's what usually happens. They call me for this kind of patient, but now we taught them what to do because we have a good algorithm and good way of identifying patient at risk. It depends who you ask. Some people will answer completely differently. But I think now we have good data to show that in low-risk patient, we don't have to treat. High risk, we treat, but mainly with ribavirin as of today for RSV. So I had many questions over the past 18 years that I tried to answer in our stem cell transplant. First, treat or not to treat. If we want to treat, do you treat everyone or only high-risk patient? How can you identify high-risk patient? Based on what? You have to have a good, concrete data to say, oh, this is patient at high risk, this patient is not. And would you use aerosolized or oral ribavirin? Because aerosol ribavirin probably is not available in most of the countries. You have only oral or sometimes IV, intravenous. So this is the first question I tried to answer. And the reason also, keep in mind, for many years we've been using aerosol ribavirin at MD Anderson, but also in many cancer centers. And this is how you do it. You have a generator here of aerosol, of ribavirin. Patients sit in a tent, and you cover them with this tent to prevent environmental contamination because it's a teratogenic drug, and they breathe in and out the ribavirin. It used to be for 18 hours in this tent. 18 hours. Can you imagine someone sitting here for 18 hours? We changed it over the past many years. We did the randomized trial where we found that if they sit for only 9 hours, 3 hours on, 5 hours off, 3 hours on, 5 hours off, it's as good as 18 hours. So at least we made it easier for a patient. But do they need to get aerosol ribavirin? And I'm going to show you data. So we showed in many of our publications, not only us at MD Anderson, but also at the Fred Hutch in Seattle, with both centers, we've been publishing quite a bit on RSV, that if you treat, you get better outcome, less progression to pneumonia. And we are the first group to show if you treat, you have impact on all-cause mortality. In this one of the publications that we did, antiviral therapy, better survival than if you don't treat patients with RSV. Then Michael Buck and Fred Hutch also showed patients who already have pneumonia, if you treat with aerosol ribavirin, you have better survival than if you don't treat at all. So it's all based on cohort studies outcome study, not a randomized trial, but showing kind of the same thing from the US, but also from Europe, per Lugman group and other people who look into that. So for many years, we showed to the world that ribavirin may have an impact on progression to pneumonia as well as mortality. So that's why most of the centers were using ribavirin. But the problem was ribavirin, we've been promoting it for years and years, until a few years ago when the price went up from a couple of thousand a day up to $30,000 a day. $30,000 per day, and usually you treat between 5 and 10 days of treatment. So talk about $300,000 for only aerosolized ribavirin. This is a huge cost, where the transplant costs probably around $600 to $1 million, but if you're treating one transplant with this, it's like 1/3 of their cost. So we found that it's unacceptable. So that's why, first, we want to see, do we need to treat everyone? And we know that some patients, they got RSV after transplant, and they do well. No progression, no pneumonia without treatment. And some, they don't do well. They progress and they die from their infection. So how can we identify this patient? So we did an important study looking at an immunodeficiency scoring index. We said, if we can score this patient with the risk factors, can we identify the one at high risk and the other one at low risk? And I know many of the centers now validated our scoring index from different cohorts around the world. The way it works, you have all these risk factors, very important risk factors, that we put them together, but each one had different weight, because we know that ANC or ALC are very significant risk factors. Age is very significant. GVHD it is, but not as much as the other ones. Corticosteroid or recent transplant within 30 days of pre-engraftment. So if you put numbers to each one, if a patient had this or this or this, you get number, and maximum is 12. So if someone has a score between 0 and 2, low risk. Moderate risk is 3 to 6, and high risk 7 to 12. And we worry really about the high risk, meaning 7 to 12, meaning they have at least 3 or 4 risk factors. And we validated that, and other centers where patients who were treated and high risk, some of them progress, but if they were not treated, all of them progress. Look at mortality. The high risk, 7 or 12 on the scoring index, mortality up to 75% if they were not treated, but we decrease it to 25% if they were treated, but it is still significant. So this is the validation cohort that we did in our center, but there's many other cohorts that validate our data that I'm not gonna go over it. So what we found that ISI is very significant, relevant for us, and many centers are using it to certify patient treatment versus no treatment. High risk or moderate risk you treat, low risk you don't treat. But we cannot use aerosolized ribavirin. It's very, very expensive, unfortunately. We moved away around a few years ago, and we started using oral ribavirin. I know in Europe, they've been using it for a long time, but only a few cases from here and there. So we looked at our data, if you're interested, it was published a few weeks ago in CID. We compared aerosolized ribavirin versus oral ribavirin. It was sequential. So as soon as we stopped using aerosolized, we started using oral, and we want to see, are we really doing a favor to patients? Do we see the same outcome, or it's worse outcome? So we looked at 127 patients, same characteristic between the two groups. No difference in risk factors, no difference in ISI scoring as well. The interesting thing that we found, there was no difference. When you compare aerosolized to oral, length of stay is the same, progression to LRI is the same, mortality is the same. So there were no difference in outcome between aerosolized and oral. When we stratify by our risk factors, by our scoring index, low risk up to high risk, also we found the same progression to LRI and same mortality. So based on this data, we concluded that oral is as good as aerosolized ribavirin. So we did well when we switched to oral ribavirin around a few years ago in this patient. But this is the only study showing that there's another cohort, much smaller number at UCLA who did the same thing. So hopefully in the future we start seeing more data coming out. So my recommendation for RSV, treat moderate to high risk, treat at URI stage. Don't wait until patient get pneumonia, because then you will get much into trouble, and they may die with respiratory failure. And oral ribavirin is still an option. And I give you, even with oral or aerosolized, I had a case 3 weeks ago when I was rounding on service, my first RSV case for this season. Patient pre-engraftment got the conditioning regimen, became neutropenic, but did not engraft. It was haploidentical patient. He was doing fine, clinically libido fever. We tested for RSV. It was positive. 1 week later, progressed. Now he's intubated in the unit, even when he got aerosol oral and then later on aerosol. So pre-engraftment is very high risk period, and we were very aggressive, but we couldn't prevent pneumonia and we couldn't prevent respiratory failure. He's still alive. Hopefully he will recover from it if his count will recover. So it is very serious infection that we see. Let's move on, talk a little bit about parainfluenza. A few words on parainfluenza. Parainfluenza is also very common respiratory virus causing infection transplant, but also in hematologic malignancy patient. Incidence 18%. We worry also about progression, which could be up to 44% to pneumonia. It depends on the study that you look at. But overall mortality could be up to 50% in some of the cases. No treatment. Nothing. What you do for parainfluenza, we know they progress, they die, but there's no treatment. We looked at all published data using ribavirin-based therapy. We found there's no difference between treated or not treated, but also when we look at mortality, if they have pneumonia, no difference with ribavirin. So that's why we never use ribavirin at MD Anderson for parainfluenza. We use sometimes IVIG when they have pneumonia, and we saw some result. But what about the new drugs, DS-181? It's a new molecule which cleaves the sialidic acid receptor on our epithelial cells. And what happens usually is that to prevent entry of the virus into the cells. So it will prevent replication. It's had impact on influenza and parainfluenza. The good news is I presented this data at ID Week a few weeks ago. Phase 2, we finished it. And the data, first, if you look at the primary endpoint, we did not meet the primary endpoint. And I will tell you why. Because it was not the right primary endpoint, which was clinical stability survival rate. We treated 110 patients, 10 days inhaled therapy, once a day for parainfluenza pneumonia. And some patients were already on mechanical ventilation. I will tell you something. Anyone on mechanical ventilation, whatever you do, any antivirus you give, it's too late. So that's why we learned from this trial that we're not going to enroll patients on mechanical ventilation, because if you give them whatever, it's not going to work. It's too late. And viral infection depends when you catch it, then you can make a difference. But, so we focus on patients who were only on oxygen before intubation, and on stem cell transplant. What we found is, if you treat patients with parainfluenza pneumonia within 1 year after transplant, you have better outcome, better clinical stability survival, better return to room air. More patients who were on oxygen return to room air than the one who on placebo. Better mortality as well, or better survival in this patient. So we found that it has an antiviral effect, but you have to pick the right design and the right time of using it, and the right patient population. So we are moving on with a phase 3 trial, and the FDA approved it this week to let us have different primary endpoint and only enrolling patients after transplant within 1 year, or even leukemia patient on chemotherapy, and only patient on oxygen, not mechanically ventilated, for the efficacy endpoint. Not. So stay tuned. Hopefully by next year we're going to start the trials. It's going to be international trial, and try to get this drug to the market, because it's well needed in this patient population. My last slide on influenza, quickly. Influenza has big impact on our stem cell transplant population. I'm going to show you two important outcomes. If you treat early, no one progressed to pneumonia. Within 48 hours of symptom onset, no stem cell transplant, even higher risk, don't progress to pneumonia. And also, if you treat early, no one died. So we have good treatment, but you have to act quickly within 48 hours. We tell our emergency room physicians, a patient coming in with URI, with respiratory symptoms, treat, then order the diagnostic test. Don't wait. Give them empiric therapy. If it's influenza, you continue. If not, you stop. But you cannot wait, because if you wait, look at the death in high risk versus low risk, up to 30%. So if you want to remember something for influenza, treat early on for 7 to 10 days with oseltamivir. That's what we do in our institution, and you can prevent death. So in conclusion, respiratory viruses are common cause of URI and LRI in transplant. The scoring index is useful not only for RSV, but also for other respiratory viruses like PIV or influenza. Early therapy is very important at URI stage to prevent LRI and mortality, but still we need more antiviral. We don't have many for these viruses, and to improve outcome after transplant. And I'm going to acknowledge my research team, and thank you.